Okay, hello everyone. Welcome to today's session. It will be on amyloidosis, renal amyloidosis, presentation, diagnosis, and management. I'm Poyan Mehr, nephrologist at Kaiser Permanente, San Francisco, and I have the pleasure and delight to introducing my friend and colleague and collaborator, Dr. Tingting today.
Thank you, Dr. Poyan Mehr, for that kind introduction. Hello, everyone. Good morning. It might be afternoons in some places. Thank you for being here today. It is my pleasure to give this talk on renal amyloidosis today. I'm going to share my screen. Okay. Does everyone see my screen?
Yes.
All right. Okay. Get started. So these are my disclosures. Now is relevant to today's talk. I would like to start with a brief review of the pathogenesis of amyloidosis, followed by a discussion on the epidemiology and clinical presentation. But I'm going to spend most of my time today on the diagnosis, management, and prognosis of renal amyloidosis. Now, amyloidosis is a group of disorders that results from the extracellular deposition of insoluble fibrils, which can then lead to progressive organ dysfunction. Now, why amyloid formation occurs is not entirely clear. The assumption is that there must be some type of cellular or molecular distress that's causing this. Now, this is a simple schematic illustrating how amyloid fibrils are formed. Now, the amyloid precursor proteins can exist in their native states, intermediate or partially unfolded states, or unfolded states. These states are in equilibrium with each other. Now, the unfolded states and the intermediate states are fairly unstable, and they're prone to misfolding and self-aggregation. Now, when the right conditions are met, whatever those conditions are, it could be the type of genetic mutation that's leading to an unstable protein, or the local environment, such as the pH, the temperature, the degree of phosphorylation, the type of proteolytic cleavage, etc. So when these conditions are met, these monomeric proteins can self-aggregate, forming these oligomers. When the number of oligomers reach a critical concentration, you can actually then form a nucleus, which is a catalyst that rapidly recruits additional monomeric proteins, polymerizes them, forming these fibrils. And during the process of this assembly, these structures actually transform into these beta-pleated sheets and forming these amyloid fibrils. These fibrils actually can break off, and the endings can then recruit more of these proteins. And this process goes on. And with time, you can see this exponential growth in the number of the fibrils. And the process goes on until all the monomeric proteins are used up. Now, these fibrils can associate with themselves, and they can associate with other molecules in the surrounding area, including chaperone proteins such as serum amyloid protein. They combine and deposit in the extracellular tissue as very stable, insoluble structures that are very resistant to degradation. Now, on light microscopy, these fibrils look like this, randomly arranged, straight non-branching little filaments that are about 7 to 12 nanometers in diameter. These beta-pleated sheets actually combine to Congo red dye very easily, which can then give you this very characteristic apple green birefringence under polarized microscopy. Now, when the amyloids deposit in the extracellular tissue, it can really literally cause physical disruption to the architecture of the tissue, leading to organ dysfunction. Additionally, the oligomers I talked about, plus some of the smaller fibrils, actually can enter the cells via endocytosis. And once they're in the cells, they can actually cause direct cellular toxicity via a number of mechanisms, including disruption of the endosomal and lysosomal pathways, their function, impairment of mitochondrial function.